Hi, I'm Dr. Paul Mason. Misdiagnoses are very common in musculoskeletal medicine, and I've personally had my fair share. Many of these were due to my lack of awareness of alternative diagnoses, because you see what you look for and diagnose what you know. As we often say in medicine, it's or me, I just didn't see it. I'd like to start with a condition called enthesitis, which is basically a fancy way of saying an insertional tendinopathy. In other words, a problem where a tendon joins onto the bone, in this case, the Achilles tendon at the back of the calcaneus. This is as opposed to a mid-substance tendon problem located more centrally within the tendon. And the reason differentiation is important is that the management between the two should be very different. Insertional tendon pathologies, or enthesopathies, often do not respond to conventional treatment, and this is because they have a different underlying pathology. While load is a significant contributor to a mid-substance tendinopathy, enthesitis is often as a result of autoimmune inflammation. When the immune system attacks the tendon-bone junction, you'll often see imaging like this, where inflammation within the bone is shown by the bright signal indicating edema. The tendon, on the other hand, looks fine. And enthesitis can occur at basically any tendon-bone junction within the body. Here you can see that a patellar tendon insertion on the left or a posterior cruciate ligament insertion on the right are both associated with significant bony edema. And this tendency to occur at multiple locations is useful diagnostically. It's useful to palpate other sites of tendon insertion, including the medial and lateral epicondyles at the elbow, the patellar and quadricep tendon, as well as the Achilles. And while not technically a tendon, the plantar fascia insertion is a common site of enthesitis, and this explains why plantar fasciopathy can be such a recalcitrant condition to treat. Also, being an inflammatory condition, the pain of enthesitis tends to be worse on waking, or after prolonged periods of immobility, very different to the load-based symptoms that you tend to see in mid-substance tendinopathies. And with the bone being so involved, enthesitis is often associated with bone spurs called enthesophytes. These are common at the heel, both at the Achilles and plantar fascia insertions, and around the patella, and should not be confused with osteophytes, often seen in association with osteoarthritis. Also useful to know is that enthesopathies are frequently associated with a group of conditions called seronegative spondyloarthropathies. These are basically a group of autoimmune diseases which cause inflammatory joint pain, and the prefix seronegative is just a fancy way of saying that the normal blood findings of rheumatoid arthritis are absent. Basically, another way of saying non-rheumatoid inflammatory arthritis. There are 4 conditions which fall under this heading of seronegative spondyloarthropathy: reactive arthritis, ankylosing spondylitis, psoriatic arthritis, and entropathic arthritis. Ankylosing spondylitis is well known for contributing to something called bamboo spine, basically ankylosis or fusion of the vertebra. And the resultant loss of range of spinal flexion can be detected with a modified Schrober test, where the lumbar spine fails to elongate normally during forward flexion. Features of psoriatic arthritis may include skin lesions, which can be under the hairline and are often mistaken for dandruff, or commonly on the elbows and the knees. Characteristic nail changes can also be seen in association with psoriatic arthritis. Entropathic spondyloarthropathy refers to its connection with gastrointestinal pathology, and patients frequently have a history of abdominal pain, bloating, or a diagnosis of inflammatory bowel or celiac disease. And one simple symptom which is often overlooked is mouth ulcers, the mouth being part of the gastrointestinal tract. And interestingly, enthesopathy in many patients often improves on a gluten-free diet. So if you have a patient with gut symptoms and an enthesopathy, it's always something worth considering. One thing these 4 conditions have in common is the ability to cause sacroiliitis, or inflammation of the sacroiliac joint. And if someone has a good going sacroiliitis, Patrick's test, or even just direct palpation in prone of the sacroiliac joints is almost certain to be provocative. So the next time you see a tendon pain, ask yourself, could this be an enthesitis? Because it may well change your management. I'd like now to move on to an underappreciated cause of groin pain in young athletes. There are a number of different names for groin pain, including pubalgia, osteitis pubis, and adductor strains. Interestingly, many of these diagnoses may actually relate to an apophysitis of the pubis, which has only fairly recently been described. An apophysis is formally known as a secondary ossification centre attached to another larger bone by cartilage. An apophysis serves as a site of attachment for a tendon or a ligament, and the cartilage connection represents a point of weakness, and this can be vulnerable to injury due to repeated tensile stresses. Here you can see some apophyses around the elbow in a skeletally immature individual. With skeletal maturation, these apophyses will fuse to the underlying bone. In 2015, this paper was published in the British Journal of Sports Medicine, identifying that the pubis has apophyses which up to that point had not been fully appreciated. You can see these apophyses on imaging here, underneath the attachment site of adductor longus. All 26 subjects reported on in this paper had painful resisted adduction, and all 7 subjects who underwent a CT scan were shown to have an unfused apophysis. And note that one consistent finding of groin pain is the presence of pain on contraction of the adductor muscles. Further, all 26 subjects had changes on X-ray consistent with osteitis pubis, and were the unfused apophyses not identified, this is probably what they would have been diagnosed with. But the most striking finding of this paper was that these apophyses remained open or unfused and vulnerable to injury until at least the age of 21, and in some cases up to the age of 26. So before you refer a patient under the age of 26 with groin pain for an injection or even a surgical adductor release, consider that this may simply be an apophysitis, and load management may be all that is required. I'd like to now talk about medial tibial stress syndrome, not so much because it's a difficult diagnosis to make, but because the commonly accepted theory about it being caused by the repetitive pull of the soleus muscle is wrong, and this might lead to mismanagement. One of the fundamental flaws in the old theory of medial tibial stress syndrome being caused by the pull of soleus is that, as often as not, the soleus muscle doesn't even insert onto the lower tibia. The old assumption that medial tibial stress was not primarily a bony pathology is understandable given that bony injury was not readily seen on X-ray or CT. However, it is now well known that medial tibial stress is absolutely associated with bony microfracture, and this explains why factors relating to bone stress and bone health, including impaired bone mineral density and repetitive high impact forces, rather than repetitive muscle contraction per se, are the most important risk factors. And while evidence is limited, the use of shock-absorbing inner soles is the most promising intervention studied so far for prevention, and this is consistent with bone stress and high impact forces being the issue. So rather than doing what I used to do for this condition 20 odd years ago, including friction massage and suction cups, a load management approach with a focus on bone health is likely to be much more effective. I'd like to now talk about a common cause of anterior knee pain, which according to several experts is quite underdiagnosed: medial plica syndrome. A knee plica is basically persistence of embryological tissue that normally involutes or disappears during fetal development. This involution, however, is incomplete in many people, the result being persistence of a band of tissue, often thick and fibrotic, within the knee. While there are 4 common locations for knee plica, the medial one is by far the most problematic. In one series of 400 knees explored arthroscopically for knee pain, without other cartilage, ligament or bone damage, 72% of patients had a medial patellar plica. and when the knee moves into flexion, this medial plica can dig into the medial femoral condyle, and this can be the result. Shown here on arthroscope, the medial femoral condyle has a cartilage defect caused by a medial plica. In fact, I've seen patients who have full thickness lesions all the way down to bone as a consequence of a medial plica. Fortunately, the clinical diagnosis is usually quite easily made. The pain is usually well localized, and a taut band of tender tissue is usually palpable medial to the patella in the 2 or 3 o'clock position simply by rolling your finger up and down. Loaded full flexion appears to be most provocative, with these patients often describing pain with squatting, stairs, or kneeling. My preferred clinical test is to palpate the painful area with the knee in extension and, maintaining my finger in position, have the patient assume a loaded squat. They will usually then be able to confirm that, yes, that is exactly where my pain is. Interestingly, they can also have moviegoer's knee with pain after prolonged sitting, which is classically associated with patellofemoral pain syndrome, and because the plica can slide over the condyle, a sense of clicking, catching, or giving way is not uncommon. Unfortunately, imaging is unreliable at picking up a symptomatic plica, so it essentially remains a clinical diagnosis which can then be confirmed arthroscopically. Of course, imaging has a role in excluding other causes of knee pain. In terms of treatment, I find that understanding flexion is most problematic, and educating patients and finding alternative movement strategies can be useful. Steroid injections into the plica can, in some cases, settle things down, but without activity modification, it just tends to recur. Ultimately, if conservative therapy fails, it can be effectively dealt with surgically. I'd like to now talk about several conditions that can be mimicked by spinal nerve root irritation. The list is surprisingly long and includes levator scapular syndrome, piriformis syndrome, greater trochanteric pain syndrome, sacroiliac joint syndrome, quadrilateral space syndrome, T4 syndrome, and more. The thing that should stand out here is that they are all syndromes, and the term syndrome tends to be used when a true understanding of the cause of a condition is lacking. You see, syndromes are basically just lists of symptoms that cluster together, without a deep understanding of why. I submit that many people with these syndromes actually have diagnosable pathology attributable to nerve root irritation. The capacity of disc bulges or other spinal pathology to irritate spinal nerves is well known, with resultant disruption of nerve function and pain. This is known as a radiculopathy, and disruption of the signal along the nerve from the skin to the brain can cause sensory disturbances such as numbness, paresthesia, with pain also being described as shooting or electric being felt in a dermatomal pattern. Interruption of the signals from the brain to the muscles telling them to contract can lead to weakness. But not every nerve compression is significant enough to interrupt conduction along the nerve, or at least not noticeably. So the question is, does irritation of the spinal nerve without disruption of conduction cause any symptoms? And the answer is yes, and we also know why. Surrounding larger nerves are smaller nerves. That is, the nerves themselves have a nerve supply. Unlike the brain, nerves themselves can feel pain. Not just cause pain, as with a radiculopathy, but nerves can feel pain themselves. These small nerves are called nervi nervorum, and irritation of these nerves can cause not a radicular pain, but a visceral pain. This visceral pain arises because the signals from the nervi nervorum are carried by sinovertebral nerves, which you can see here, and these feed into the sympathetic ganglia before their signals reaching the central nervous system. And by definition, any pain carried through the sympathetics is visceral pain, and visceral pain, visceral referred pain, is poorly localized. This is why irritation of the posterior interosseous nerve, a motor nerve, causes a poorly localized lateral elbow pain, and why carpal tunnel pain patients often feel an ache proximal to the site of nerve compression. This paper here provides us with clear evidence that spinal nerve root irritation can masquerade as musculoskeletal syndromes. From 1958, a time when ethical review boards were perhaps not as robust as they are today, this research is unlikely to be repeated, which is why it's so important not to ignore it. If we only rely on contemporary research, we're effectively throwing away knowledge. This paper documents the results of what happened when a surgeon passed a nylon thread around nerve roots in the lower back and left the free ends protruding from the skin, later tugging on the threads to see what happened. Pulling on threads around the L5 nerve root led to pain in this distribution, very similar to what might be expected in piriformis syndrome, a condition which many experts argue doesn't actually exist. It's also common for pain to refer out more laterally in a pattern often diagnosed as greater trochanteric pain syndrome. And this is well known by neurosurgeons who see many patients with nerve compressions who have lateral hip and gluteal pain. In the same patient, this was a pattern of pain arising from pulling the thread wrapped around the S1 nerve root, this being a very common presentation, well known as back-related hamstring pain. One of the interesting things about this type of referred pain, visceral referred pain, is that patients are not able to distinguish it from muscle ache. Think about that for a moment. A nerve is irritated, and the quality of pain is such that the patient will describe it as muscular. It's no wonder that given the locations of referral, these pains are often misdiagnosed as being of muscular origin. And this is the pattern of pain experienced by another subject in the same study after irritation of the S1 nerve root, localized around the ischial tuberosity, and perhaps liable to being diagnosed as ischial bursitis. And cranial or cervical nerve root irritation also commonly presents as musculoskeletal pain. This Japanese paper examined 50 patients with cervical nerve root compressions who underwent nerve root decompression surgery and examined what happened to the muscular type pain they were experiencing in different regions after different nerves were decompressed. And they found that different cervical nerve roots had a relatively predictable pattern of referral. And again, this pain was of a poorly localized muscular quality, making diagnoses of levator scapular syndrome, T4 syndrome, or quadrilateral space syndrome quite understandable. And my understanding of these referral patterns arose when I had a patient once, an elite athlete I was managing through a season, and he was referred for a CT-guided corticosteroid injection to assist with the management of a newly diagnosed nerve compression in his lower back. And for most of the season prior to that point, he had been suffering from what had been diagnosed as sacroiliac joint pain. And after the spinal injection, he reported that the long-standing sacral region pain he'd been experiencing had all but disappeared. And this illustrates the role of diagnostic image-guided corticosteroid injections in assisting diagnosis of visceral referred pain arising from spinal nerve root irritation. A combination of local anaesthetic and corticosteroid is injected adjacent to the nerve, and if there is an immediate and a profound reduction in pain due to the action of the local anaesthetic, then it suggests that the injected nerve may be responsible for the symptoms. Here you can see the needle of a CT-guided injection, a CT-guided cervical nerve root injection in one of my patients. And this is the report after her injection. She had clinical signs consistent with both C5 and C6 irritation, which is where we injected, and her symptoms included a strong ache over her shoulder blade, which completely disappeared after the injection. And as well as guiding treatment by providing an accurate diagnosis, these injections can in some cases themselves be therapeutic. One diagnosis I often see being made is that of low back pain caused by gluteal dysfunction. And this is perhaps understandable, as there is a significant body of literature on the association between the two. The problem is, an association is quite different from causation. That is, just because gluteal weakness often coexists with low back pain doesn't necessarily mean it is the cause of low back pain. It's it's a case of chicken or the egg. Which one came first? And I believe it is back pathology, more specifically nerve root compression, that leads to gluteal dysfunction. First, make note that the superior and inferior gluteal nerves, the nerves supplying the gluteal muscles, are reliant on supply by the L5 and S1 nerve roots. Predictably, therefore, compression of the L5 and S1 nerve roots can lead to gluteal weakness, which is why a Trendelenburg gait caused by hip abductor weakness is considered a sign of lumbosacral radiculopathy, as is gluteal wasting. Here you can see atrophied gluteal muscles as a consequence of lumbosacral nerve root compression. And if weakness is caused by a neurological problem, then a strength training program is predictably going to be ineffective. Of course, many therapists have made the observation that return of gluteal function is associated with improvement in low back pain, but this doesn't reflect the effectiveness of a gluteal strength program, rather the improvement in the underlying radiculopathy. This is also true of training for an S1 related calf weakness or atrophy. Resolution of the nerve issue is needed before recovery of strength is possible. And this concept of nerve compression related weakness also explains why segmental atrophy of multifidus, a small muscle of the spine, is strongly associated with back pain. Being a segmental muscle, it derives its innervation from adjacent nerve roots, and disruption of these nerve roots leads to localized atrophy. And again, recovery of nerve function is necessary for recovery of muscle strength and function. So, if you see a patient who's been diagnosed with muscle weakness as a cause of their pain, perform a neurological examination. You might find a nerve compression explains both the pain and the weakness. Let's now talk about trigger points. It's fair to say I'm a fan. In fact, I've authored a section on them in a sports medicine textbook. But while they're commonly diagnosed as a problem in their own right, they should more correctly be considered as a symptom of another problem, in particular, nerve root irritation. Take gluteal trigger points. Research published in 2016 found that the presence of trigger points in the supralateral gluteal quadrant was more than 90% specific for the presence of a lumbosacral radiculopathy. Basically, if a patient has trigger points in this area, they are very likely to have a nerve problem. So while treating trigger points will likely give a patient some pain relief, don't forget to address the root cause. And this holds true for the cervical spine as well. In my experience, many of the conditions I've presented here today are common. And there's a saying in medicine: when you hear hoofbeats, think horses, not zebras. In other words, these common diagnoses are common. It's just that when we don't know much about a condition, we tend to assume that it's quite rare. I hope I've stimulated some of you today to explore these pathologies and that you might diagnose them in future. Thanks very much.